In Chapter 15, we will be covering the ankle and lower leg. As far as the anatomy of the ankle, the main bones and ligaments will be covered on this slide. So we have three main bones that make up the talar crural joint. So talar crural is right here. That is the name for the true ankle joint. So the bones that make up that joint are the tibia here, the fibula here, and then they meet and create a little dome or a little covering for this dome of the talus right here. So it's that three-way intersection of these bones that makes up that very important talar crural joint where most of the stability of the ankle comes from. At that joint, there is plantar flexion and dorsiflexion allowed. So basically you point and flex the toe from that particular joint. So from right here, that's where that's happening. So pointing up and down is happening from the talar crural joint. We also have another joint, it's called the subtalar joint. So that's right here. So that's underneath the talus, between the talus and the calcaneus. And that's where that's the joint where we get inversion and eversion. So that's the foot turning in and the foot turning out. So we have four main motions at the ankle, but they happen in two different joints. The ligaments of the ankle on the lateral aspect of the ankle are basically the anterior talofibular. So this is the medial malleolus that runs, or I'm sorry, the lateral malleolus that runs right here. That's the bottom of the fibula. We have the anterior talofibular that comes off the front of that. Very important ligament. It is the most commonly sprained ligament in the ankle. We have our calcaneofibular, so that runs from the fibula to the calcaneus right here. And then we have the posterior talofibular, which runs from the fibula to the talus in the back of the ankle, so kind of through here. So those are our main lateral ankle ligaments. When we're talking about a lateral ankle sprain, those will be the ones that we're talking about getting injured. So more superiorly, more towards the top of the fibula, we have our anterior and posterior tibiofibular ligaments. So the anterior tibiofibular ligament is the ligament that runs between the tibia and the fibula up here. So that would be considered a high ankle sprain. And there's also one in the posterior aspect of the tibia and the fibula. So that's the high ankle sprain. This is the normal ankle sprain down here, the talofibular. They're not very different. They're really close together with the naked eye. So you really have to kind of know where you're looking to understand the difference between where those two ligaments are. We also have an interosseous membrane that runs between the bones as they go up. So the ligament, say for instance, might be right here, the posterior tibiofibular in this picture, and then we'd have an interosseous membrane that runs up the middle here of these bones, and that's another structure that can be torn or sprained when somebody has a bad sprain. As far as the muscles and tendons of the ankle and lower leg, on the posterior lower leg, we have the gastrocnemius, or calf implant muscle there. And then we also have the soleus, which is deep to the gastrocnemius. So the soleus would be coming more through here. So it's more of a flat muscle that runs most of the way up the lower leg. And then those both attach into the Achilles tendon. So they have a similar ending point. They're almost like almost like twin muscles. They run in a very similar pathway. As far as the ankle, so those are the foot and ankle flexors. As far as the ankle extensors, those are going to be in the anterior lateral leg. So they're going to be on the pinky toe side, and they're going to be primarily on the very anterior aspect. So the tibialis anterior is an example, or the toe extensors. So that we have the tibialis anterior here, and then the extensor digitorum longus. So the toe extensors would also be coming from a similar region there. So the anterior lateral aspect of the lower leg there. The everters, or the muscles that pull the toe out to this, the little toe out to the side or laterally, would be on the lateral leg. So we have the peroneus longus, peroneus brevis, and peroneus tertius right here. So those are running basically through this general region-ish. Those are our everters. And our inverters are deep on the medial side and slightly posterior part of the leg. So those are our Tom, Dick, and Harry muscles. So again, those are our muscles that will be running behind the medial malleolus to go under the foot, as we covered in the foot lecture. So toe flexors for the big toe and the littles. So tibialis and the tibialis posterior. And again, the flexor digitorum longus and the flexor hallucis longus. As far as ankle and lower leg injury prevention, Achilles tendon stretching can be really important. So we're showing that on these slant boards. So the individual here is stretching on these slant boards. This is a gastrocnemius stretch, and this is a soleus stretch. By bending the knee, you focus more on the soleus there. So we like to do straight leg and bent leg calf stretch. That can help prevent overuse and acute injuries possibly, but definitely that tends to help with shin splint pain. Strength and neuromuscular control are very important. Specifically, balance training is really important. So you can use an unstable surface like a balance board like this, or I'll often tell people who've had chronic ankle injuries, just stand on one foot while you're brushing your teeth, for one foot for 1 minute, the other foot for another minute, and then you've balanced a bit. If it's too easy to do it that way, you can stand on a throw pillow or swing one foot as you're doing it, or something along those lines, just to throw yourself off balance. But balance training will help prevent chronic ankle sprains and knee injuries possibly as well. As far as strength training, the individual can do inversion and eversion with bands or cables for the ankle. That's also very helpful. Long term, though, the balance training probably makes a bigger difference. The other thing would be proper footwear. So different kinds of footwear can make a difference. So wearing high tops for basketball is actually protective of the ankle. The other thing is being careful with cleat position and cleat length for things like football and rugby and soccer. The longer the cleats are, the more likely your ankle is to, or your foot is to get stuck, and then your ankle will turn when your foot should have. As far as preventive taping and bracing, taping isn't really great at preventing injury. Some people who've had previous ankle injuries will feel more comfortable if they're taped or braced, and that's fine. But as far as a general preventive tool, it's not really, really helpful. But bracing is just as effective as taping, and it can be more cost efficient. A good brace, such as the one shown in this picture, that has the straps that pull up on either side and the laces that go down the front. A good brace like that is probably going to run you about $30 to $40. But over time, that could save you money. It depends on how much you're getting taped, because one roll of tape at a good price is probably around $3. That's what I sell it for. You may be able to find tape for cheaper, but it's usually pretty cruddy tape. So basically, if you get 10 to not even 15 uses out of the ankle brace, it's going to be cheaper than the tape would have been. Next, we'll go over assessment, starting with our HOPS protocol, starting with history. Remembering that the information provided here is for informational purposes only and to help with triaging injury. So for an ankle injury, we're going to want to know their past history of injury. Have they had any previous ankle or foot or lower leg injuries? We're going to want to know the mechanism of injury. So how did it happen? Did the foot twist in or out? Or, did they fall on it? There could be any number of things we would be asking. When does it hurt? So for an acute ankle sprain, say for instance, that may not be the most helpful question because it probably pretty much hurts most of the time. But if it's for a shin pain, that could be really helpful. We're going to want to know the type, quality, and duration of their pain. Any sounds or sensations at the type of injury or sense. So did they hear, feel a pop or a snap? Or any crunching? How long have you had problems? So again, that's more helpful for chronic injuries than for an acute ankle sprain. And have they had any previous treatments? If they have, did they help or not? All of those things would be helpful information to know. As far as observation, ideally, we would be able to see the person standing up prior to starting to evaluate this because it just makes it easier to see how they move before we're talking to them, but sometimes we don't, so we may have to ask them to get up and walk for us. But we're going to check for postural deviations, so we'll look for genu valgum or varum. Genu valgum is when the knees are stuck together like they're stuck together with gum. Generally speaking, if somebody has genu valgum, the arches will fall and the person will have pes planus as well. That's just kind of a normal postural deviation, or two normal postural deviations that go together. If someone has genu varum, then they tend to supinate or put more weight on the outside of their feet actually instead of on the arches. We might also want to see, do they walk with their toes in or more out? Because that will give us some information about how they're moving normally. We're going to want to look and see, are they having any difficulty walking? Are they limping? Are they changing their gait at all? Then we're going to want to, that's assuming they can walk. If they're not able to walk, then we'll just primarily start with looking for deformities, asymmetries, or swelling. But we'll still check that even if they can walk. We'll want to check the color and texture of the skin, checking for heat, redness, and any other changes that the person might have. We'll want to observe, is the person in obvious pain? And is their range of motion normal? So assuming if they can do it without causing too much pain, we may ask them to bring their toe back towards them, point their toe toward the ground, bring their big toe in, and then bring their big toe out to check those 4 ranges of motion that the ankle can do normally. If the person has an obvious deformity, I probably wouldn't ask them to move too much, but that's more if they just had an acute injury that we were trying to check and see if they could move it normally. And I usually tell them, if you think it's going to hurt more, don't do it. As far as the palpation portion of our HOPS goes, for the ankle, we're going to begin with the bony landmarks and progress to soft tissue. So generally speaking, we'll find the lateral malleolus first if their pain is on the lateral side, and then we'll palpate out from there. The person pointing in this picture is actually pointing to the sinus tarsi. So not only is that the place where swelling tends to go with a lateral ankle sprain, but that is also often where people will have pain if they've sprained their anterior talofibular ligament. So we want to palpate the soft tissue, so the ligaments, so the anterior talofibular, possibly the calcaneofibular, and the posterior talofibular. We can palpate the tendons as well. So this would be our peroneus brevis that's coming through here. We can see it very clearly on this particular individual. We can try to palpate as many of the peroneal tendons as we can find, kind of coming through the lateral aspect of the ankle here. the individual had a medial ankle injury, we would start with the medial malleolus and then work our way around to palpate the deltoid ligament and then try to find those Tom, Dick, and Harry tendons and just see where they're tender. So we're looking for areas of deformity, swelling, and localized tenderness when we're doing that palpation. As far as special tests in our HOPS protocol, we will be doing a few different tests, some for fracture, some for ligament laxity, and one for a tendon to rule out tendon rupture. So our bump test is for a test for fracture. So basically we just kind of whack the bottom of the person's heel with the heel of our hand. And we do that to see if they're having any pain away from where we hit. So when we say a special test is positive, that means it's not a good thing. If a special test is positive, that means that we're suspicious that they have the injury we're testing for. So if we get pain at a fracture site higher, our suspected fracture site higher up, so somebody had a pain in their fibula higher up here, when we smack them on the bottom of the heel, then we would be suspicious for that painful area being a fracture. As far as the tap test, it's a similar idea, but we just tap with our finger on the, say for instance, the lateral malleolus here if we're checking for a fracture up here on the fibula. That would be a tap test. Just kind of tap with one or two fingers. Next, an anterior drawer test is when we stabilize. We are going to stabilize the lower leg here with our top hand, take our bottom hand and cup the heel, and then we're going to try to pull the heel forward. If the individual has laxity or looseness in one of their lateral ankle ligaments, then that is going to move farther than the uninjured side. So say for instance, if their anterior talofibular ligament was damaged, so kind of coming through, I guess that's not the best angle, but kind of coming through there, if we pull forward on that, that's going, and it's stretched out or injured, it will move the whole foot forward farther than the other side. So that's for an ankle sprain, we'll pull the heel forward. Positive could be for pain over the ligament and or laxity, depending on how bad the sprain was. For a talar tilt, this is also for ligament laxity or ligaments ankle sprain. If we're looking for a lateral ankle sprain, we're going to twist the foot in. So basically we're trying to take this side of the foot and twist it under, so the big toe will come up more and the pinky toe will come down more. So twisting under, and we're doing that same cupping position with our hand under the heel. So we'll have a positive for pain over the ligament site and or laxity, so it may move a little farther than the other side. We can also do a talar tilt for inversion or twisting the big toe out towards the pinky toe, so twisting under the opposite direction. That would be for the deltoid ligament or a medial ankle sprain. Our Thompson squeeze test is shown here on this slide, or on that picture. So that is for checking for an Achilles tendon rupture. So what we do there is we squeeze the calf with our hands, and we try to do them both at the same time. And we're going to look for the foot to plant or flex. Usually it's a pretty small motion, but it will do it a little bit. The toe will point. This side clearly does not plant or flex. The foot stays at a 90-degree angle to the calf. So that's showing us a positive Achilles, it's positive for Achilles tendon rupture. So this individual, I guess, they had marked here, so they probably had a palpable divot or dent in their Achilles that the tester could feel prior to taking the picture. So assuming that all of those other special tests are okay, and the person isn't really showing us signs of anything else going on, Then we can have them try to do some functional tests to see if anything bothers them. We can ask them to do calf raises, to walk on their heels and then walk on their toes. We can ask them to hop, run straight, run to the side, do figure eights, and cutting possibly. Usually if I think somebody has maybe a minor ankle sprain and we're trying to see if they can go back to play, I may have them do the calf raises and walking on the heels and toes without being taped, but usually before I have them start doing a lot of hopping, I'll try to tape them just because I don't want them to aggravate their ankle right before they go back in. But that's kind of a judgment call based on the clinician's decision. As far as our injuries go, we're going to talk about lateral ankle sprains first. Lateral ankle sprains are our most common injury in sports. And in fact, the ATFL, or anterior talofibular ligament, is the most commonly injured ligament in sports. We injure that ligament, shown here in this particular picture, by doing an inversion and plantar flexion. So we're doing an inversion with the toe pointed slightly. If we were to injure the CFL, or the ligament more directly on the side of the ankle, that happens primarily from straight inversion. That's not as common, generally speaking. It can happen if somebody lands, comes down on somebody else's shoe, like say for instance in basketball, or if they just land on the side of their foot from a jump. But generally speaking, the ATFL is injured first, and then if that ATFL is torn completely, then sometimes the CFL would be damaged next. If that is torn mostly or completely, then the PTFL would be damaged next. So the PTFL is not usually injured independently of the other two because it is in a slightly more protected position, because we usually just don't dorsiflex and invert like hard. So it's just kind of an awkward position to be trying to sprain your ankle in. Signs for ankle injuries would be pain, laxity of the ligament with testing for the anterior drawer test and the inversion or eversion, or the inversion test, excuse me. They could have edema over the lateral ankle, ecchymosis, so bruising, dysfunction, possibly, so they may not be able to walk on it normally or run on it. Our treatment would be price. Rehab would be restoring range of motion. So sometimes we'll have the person draw ABCs with their big toe, say for instance, to help with the range of motion. Strength. We can do this with our hands as clinicians, or we can have them use TheraBands. Balance. Starting on a stable surface and moving to an unstable surface. And taping or bracing if they're going back to play quickly. RTP, or return to play, depends on the grade of the injury. For grade 1 injury, they could possibly return immediately with taping or bracing, depending on how they're feeling. For a grade 2 injury, it's usually going to take 2 to 6 weeks, depending on if it's more than one ligament injured, or how much swelling or how bad the actual grade 2 is, remembering that there's a few subcategories also within the grade 2, so if it's on the more mild end of the spectrum, they'll probably be able to recover more quickly. For a grade 3 or a complete tear or sprain, then that's usually going to take 4 to 12 weeks. So just because somebody has a grade 3 or a complete tear of the ligament of the ankle doesn't necessarily mean that they're going to need to have a repair or surgery. Usually people heal very well from those. The ligament will just be looser from now on. Medial ankle sprains are less common than lateral ankle sprains for a lot of different reasons, but if we do have a medial ankle sprain, that happens from the big toe being turned outward, and the ligament that is injured is the deltoid ligament here, coming from the medial malleolus down to the navicular bone of the ankle. And again, that deltoid sprain is from eversion. It's not as common, but it would be more common in things like soccer or possibly rugby. Our Our signs would be pain with walking and running, laxity with an eversion, talar tilt. They could have edema over the medial ankle, ecchymosis or bruising, dysfunction, so difficulty walking or running, and they could even have a dropped arch. So that's what that's showing here in this picture, how the individual has a dropped arch. You can see their medial malleolus is sitting right here on that ankle, and this ankle it's sitting a little higher. So there's a decent amount of difference between the levels of the malleolus there. So that's a really easy way to tell if the arch has fallen on one side versus the other. I had a water skier when I was at UCSD who had injured his deltoid ligament, and he could basically fit his medial malleolus from one ankle snugly underneath the medial malleolus on the other. So he had a decently dropped arch from his. It took him a while to recover because he couldn't wear a brace very well with his water skis. So our treatment here would be price. Rehab would be doing range of motion exercises, relatively pain-free. So ABCs again, strength, balance, first stable then unstable surface, taper brace, and also an arch pad, especially if they do have a little bit of that fallen arch, will help to take some of the stress off of the ligament there. Our return to play is going to depend on the grade of injury. So a grade 1 injury for an eversion sprain is probably going to be 1 to 3 weeks with tape and or brace. So that's not as quick as a lateral ankle sprain. These are a little harder to protect because we put so much weight through that medial side of the foot. So it's not as easy to say, oh, we'll just tape it up and it'll be okay. It doesn't work as well for a medial ankle sprain as for a lateral ankle sprain. For our grade 2 sprains, this is also going to be a little longer, so more like 3 to 8 weeks. And our grade 3s, it could be 6 to 12 weeks. The water skier that I had rehabbed probably was closer to 12 weeks, maybe even a little longer for him. Now, a high ankle sprain is going to be a similar type of motion in a way to a medial ankle sprain. We are going to get some external rotation or eversion, or we're going to get along with the foot going into a little bit of dorsiflexion as well. So we're going to get a twist out and up. And the ligament that will be injured here is going to be the most likely the anterior tibiofibular ligament. So this is the higher ligament in the ankle, so a little higher up than we had been looking before. So anterior tibiofibular is here, anterior talofibular is lower here. So slightly different positions and angles on those ligaments. Don't get them confused. The high ankle sprain is common in football and rugby because of joint movements and positions that can happen during tackling. If somebody has a high ankle sprain like this, they can also get an interosseous sprain of the membrane that comes up here between the tibia and the fibula. And that's going to be more serious. Sometimes with bad high ankle sprains and or the interosseous sprains, that could require surgery. Signs would be very painful with walking and running. High ankle sprains are no joke. They tend to hurt a lot more than the other types of ankle sprains. They could have laxity with specific special tests. They could have edema over the superior ankle, so sometimes the swelling will be a little higher, kind of through here, than a traditional ankle sprain. They could have ecchymosis or bruising and dysfunction, so difficulty walking or running. Our treatment is going to be price. They may be more comfortable in a boot, say for instance, or on crutches. It may be more difficult to make them comfortable with weight bearing than it is for the other types of ankle sprains. Our rehab would be range of motion, so gentle ABCs, strengthening with a TheraBand, balance when they can tolerate the weight bearing, tape band or brace, also an arch pad with this one, since we did do that eversion. So we're trying to support against the movement that they were injured in. Again, that return to play or RTP will depend on the grade. So this is also going to be a longer rehab along with the deltoid sprain. So 1 to 3 weeks at least with taper brace, 2 to 8 weeks for a grade 2. And I've very rarely seen people return in 2 weeks with a grade 2. Usually it is definitely on the longer side. 6 weeks is more common from what I've seen. And a grade 3, 6 to 12 weeks. So people can recover from these sprains without surgery, but there is a possibility of needing surgical intervention if they have that interosseous sprain or tearing of that membrane coming up through here, because it makes the injury a lot less stable than if it had just been a regular sprain. Our grades of ankle sprain follow the grades of sprains that we spoke about previously in our Recognizing Injuries lecture. So our grade 1 ankle sprain, the person will have mild pain and disability. Weight bearing is minimally impaired, so they should be basically able to walk mostly normally. They're going to be point tender over the ligament that is injured, and they will not have laxity with the anterior drawer or inversion test, say for instance. For a grade 2 injury, they could feel or hear a pop or a snap, possibly. They'll have moderate pain and difficulty bearing weight, possibly. So they might be able to walk on it a little bit, but they would prefer not to. They're going to have tenderness and swelling. Grade 1 ankle sprains don't always swell. Grade 2 are most often going to swell. The person with a grade 2 ankle sprain would have a positive talar tilt and anterior drawer if it's a lateral ankle sprain. So they'll have a positive for pain and possibly slight laxity, so they'll have slightly more motion on the injured side than the non-injured side. For a grade 3, they could have severe pain and swelling, hemarthrosis, so a lot of discoloration, bleeding, bruising. They probably felt or heard a pop or a snap. They are likely unable to bear weight on that ankle. They're going to have a positive talar tilt and anterior drawer for pain and moderate to severe laxity if it was an lateral ankle sprain. And they will be showing us instability due to a complete ligamentous rupture when they're trying to do anything functional or when we're trying to test them. The next injury we will discuss to the ankle and lower leg is fracture and dislocations. So our mechanism here would usually be some kind of blunt force trauma. Sometimes these can happen from car accidents or getting rolled into on the football field, say for instance in this picture on the upper left-hand side of the slide. But the tibia or the fibula can be fractured anywhere along the bone. So the tibia and fibula can be fractured together, such as in this particular photograph right here, or the tibia could be fractured independently from the fibula, or the fibula could be fractured independently from the tibia. It could be at the ankle or anywhere along the shaft of the bone. Ankle dislocations often cause fracture because the ankle is a very stable joint. So if it is going to be dislocated, usually there's a lot of force that goes behind that, and it's likely to cause, that amount of force is also likely to cause a fracture. Signs of fracture or dislocation would be pain over the bone, swelling, possible deformity. So again, this is an, oh damn, that's a deformity, versus swelling would look different. Dysfunction. So we have a set of rules we call the Ottawa ankle rules that give us some information about how to determine whether or not something is possibly fractured, trying to see if we wanted to get an x-ray on that particular injury. So one of those rules is that the person will have an inability to walk 3 steps. So that's what is meant by dysfunction. Sometimes people can walk 3 steps even when they have a fracture, but this is just one of our criteria for determining whether or not we think somebody could possibly benefit from an x-ray. Fibular fractures don't always cause dysfunction. The fibula itself, the smaller lower leg bone, only bears about 15 to 20% of the body weight. I actually had a football player practice football for an entire week on a fractured fibula, and it didn't fracture all the way. So he had an incomplete fracture, and he got a complete fracture the following week during a game when he went to go cut hard on that ankle. So he actually played an entire week of football practice with a small fibular fracture, most likely. So again, that doesn't always cause a ton of dysfunction. Our treatment here is price. So definitely splinting if we have a bad enough fracture, if we can tell that we think it's fractured. If the fracture is unstable, like the football player in this picture, we want to splint them and call 911. Or if the ankle is dislocated, we also want to call 911. Ankle dislocations are likely to cause nerve and blood vessel damage, so we don't want to mess around with those. We're going to call 911 as soon as we've realized that that person has a dislocation. If the suspected fracture is stable and they do not have a dislocation, then they could probably be okay with crutches and or a walking boot and going to the emergency room on their own. They would also be casted most likely for 6 to 8 weeks. If it's a more severe fracture, like in this picture, right in there, that person may end up having to have surgery possibly to have a rod supporting the tibia, or they might be casted for longer than 6 to 8 weeks. It just depends on how bad that fracture is and how unstable the area is. We do need x-rays to confirm whether or not somebody has a fracture. Even if their leg is hanging there like that, we'll want x-rays to see what it looks like. And if the fracture is bad enough, again, it might require surgery to fix it. If it's a small little fracture like the one down here, where the tip of the tibia just kind of got pulled off, most likely what would happen with surgery for that is that the surgeon would realign the bone and just put a little plate right here. For somebody who has a tibia fracture, more like in this x-ray up here, usually what they'll do is the surgeon will cut into the knee joint itself and put a titanium rod down the length of the tibia to help support that bone. And usually they don't fix the fibula. The fibula will just eventually kind of heal in on its own. When the individual is cleared by the doctor, they can begin rehab to start strengthening the muscles in the surrounding area and try to regain the range of motion that they've lost from being in the cast or walking boot. So less serious than a dislocation or fracture, we have tendinitis or tendinosis of the ankle and lower leg. Our mechanism for this would be overuse. So again, doing something repetitively that we're not strong enough to handle. Most commonly, the tendinosis or tendinitis will show up in the Achilles tendon. So that person would have maybe pain anywhere from here to here. That's pretty common. Other spots where we could get some tendinitis or tendinosis would be in the peroneal tendons here, or in the tibialis anterior tendon here, or possibly in the posterior tibialis tendon here. Those are slightly less common, but that is a possibility. The person will have, oftentimes they'll have either poor mechanics and or a tight calf and maybe they've been wearing improper footwear, or they could have trauma to the area. I actually did have somebody an athlete once who got anterior tibialis tendinitis from wearing a pair of basketball shoes that just happened to rub right over the tendon, and it caused some irritation. Once we figured that out and started padding the area, she improved a lot. Some signs of tendinitis and tendinosis in the ankle or lower leg would be pain with active motion and stretching, possibly feeling of stiffness, and maybe edema or swelling and or crepitus, or the creaking, crunching, type of feeling. Our treatment here would be price. So not casting or something like that, but if somebody had tibialis posterior tendinitis, we might put them in an arch support for their protection. But again, relative rest, ice, if they need compression, they could use that, and elevation if they're that swollen. NSAIDs can be helpful. So NSAIDs stand for non-steroidal anti-inflammatories, and that would be something like ibuprofen, like Advil or Motrin. The person could do rehab, so we'd want to do some range of motion. So if they're lacking flexibility in any of the motions of the ankle, we'd want to improve on that. We want to increase their strength in all their 4 directions of their ankle motion. Work on their balance, and possibly brace or tape or have them wear orthotics. If it's tendonitis, so if it's a newer acute injury, then we'd have them rest for 2 weeks. If it's tendinosis that's been around for a while, so more than a month, then we might probably do some deep massage and eccentric strengthening. So if it's the Achilles, they do 2 up, 1 down calf raises. So if I had an if I had a tendinosis in my right Achilles, I would do a calf raise on both ankles and slowly come down just with the right ankle. So on this slide, we're going to be covering kind of 2 injuries, but they are similar. So we're talking about MTSS versus stress fracture. This is most commonly in the tibia, although it could technically, somebody could have a stress fracture in the fibula possibly, but they're more common in the tibia. MTSS stands for medial tibial stress syndrome, which is more commonly known as shin splints. Basically, with MTSS, the covering of the bone, or the periosteum, becomes irritated, generally speaking from the muscles in the surrounding area pulling on it too hard. Then sometimes that periosteum can cause some irritation of the bone, sometimes it doesn't. Sometimes it's just the periosteum that stays irritated. With MTSS, the pain will be over a large area, usually the distal 2/3 of the tibia. That's common when somebody has a soleus, maybe that's very tight. They're going to be more commonly having pain in the middle third of the tibia, or maybe their tibialis posterior gets really irritated, and that could cause some pain in the distal 1/3. If somebody actually has a true stress fracture, that can happen when that irritation of the covering of the bone irritates the bone, causing a mini fracture. This is especially common when somebody has, for whatever reason, in one part of their bone, the osteoblast or the bone-making cells aren't keeping up with the osteoclast or the bone cleaning up cells. With a stress fracture, pain is localized to one spot on the bone during activity and possibly progressing to maybe having some pain after activity. With MTSS or shin splints, the person's going to have pain over a large area. With a stress fracture, you can put your finger on it, usually one spot or one very small line. Sometimes when I was in college, we actually used to take a pen or a pencil and roll it up their shin, and there would be one spot that would just light the person up, and then we'd be concerned for stress fracture. Usually with MTSS, it's just uncomfortable over a large area. Let's see what else. So as far as mechanism, both of these, the mechanism would be overuse. So again, doing something that we're not strong enough to tolerate over time. Things that can contribute to that would be poor mechanics, a tight calf, most often especially the soleus or the big flat calf muscle. Improper footwear, so that can mean different things to different people. For some people that might mean wearing barefoot shoes. For some people that might mean wearing Nike Frees or whatever. But if they're in a stability control shoe, then they're great. Or there could be lots of different things that means. And then changes in training. So especially when somebody increases their training too rapidly, so if they're doing more than a 10% a week increase, that could be a possibility of causing the person to be at a higher risk for either one of these. And also changes in training surfaces as well. Our treatment here would be an X-ray or a bone scan to try to rule out the stress fracture. Again, those X-rays usually aren't specific enough for stress fracture, but we always start there because they're more easily accessible. and if it's positive, then the bone scan isn't necessary, and the bone scan is more expensive as well. If somebody comes back as having or being positive for a stress fracture, so they do have a stress fracture, we're going to want them to rest for at least 2 to 8 weeks and address whatever mechanisms could be contributing to that stress fracture. The stress fracture is not always healed in 8 weeks. Sometimes it takes much longer. It just depends on the individual and how long it's been going on for as well. As far as MTSS, they're going to want to do activity modification. We're going to correct any mechanics that are off. Do a lot of calf stretching. Maybe try a different type of shoes, or maybe just new shoes if the person's been running in their shoes for too long, and add orthotics or an arch tape. Another type of injury that is considered more of an acute injury would be a shin contusion and or compartment syndrome. So compartment syndrome can be caused by a shin contusion. That's why we have them both here on the same slide. Our mechanism here would be a blow to the lower leg. So common in football, somebody takes a helmet to the lower leg. In soccer, if somebody gets kicked really hard. There's other times that this could happen as well. But basically, if somebody will get struck in the lower leg, and then edema will develop. So swelling will develop that can become a hematoma, and hematomas can be very sensitive, especially if they're directly over the tibia or the shin bone. If the edema is over the muscle belly, say for instance the tibialis anterior, and the swelling gets to be too much, it can cause a buildup of pressure within the compartments of the leg. So the compartments in the leg basically describe a group of muscles that's surrounded by fascia. So say for instance in the anterior compartment we have fascia tightly surrounding the tibialis anterior and the toe extensors. So those are all kind of together in one little package. But that package is pretty snugly held together. So if you get a lot of swelling in that area, there's not a lot of room for it to go because the fascia is holding on so tight. So what happens is that if we get a lot of swelling in that particular compartment, say for instance, the pressure buildup can start to put pressure on the blood vessels and nerves that run between those muscles, and it can cause damage to those nerves and or blood vessels that could cause a person to have a medical emergency. If we're having pressure that's so great that it's closing off the blood flow to the foot, the athlete could actually lose their leg. So if we notice something that seems to be compartment syndrome, we're going to want to make sure that person goes to the hospital. Our signs of a contusion would be the swelling, bruising, and they'll be point tender. The way that we can tell that acute compartment syndrome is different is that the swelling will be so great that the skin starts to stretch out and it will look shiny and tight. So, and if you touch it, it will feel like a drum. So the skin above the contusion will feel tight like a drum. Usually with a hematoma or a regular bruise, the skin still feels relatively soft. You may feel a little swollen. It's not going to feel tight like a drum. Compartment syndrome is very painful. It probably will feel achy, like as if somebody put a blood pressure cuff on you and inflated it all the way and then left it, because that's basically what's happening, is that you're squeezing really hard on all the blood vessels. The person could have a decreased pulse in their foot at the dorsal pedal pulse. They might not be able to draw their foot back towards them as well, and they might have decreased sensation in their foot. Our treatments for these things, it would be price for a contusion. And if we think somebody might have compartment syndrome, we definitely don't want to compress it anymore because it's already too compressed. So we'll just do ice, rest, and elevation and call 911 for compartment syndrome. If somebody does have a true compartment syndrome, they will likely have to have surgery to release the pressure, which is a 6 to 12 month recovery, or I'm sorry, 6 to 16 month recovery. With acute compartment syndrome, that surgery is very intense because they cut the skin and the fascia open and they just leave it open for days until the swelling goes down. So the person will also have very large scars from that. There's another type of compartment syndrome called chronic compartment syndrome, And that's an overuse injury, so it's not an emergency. And it's actually usually kind of lumped in with MTSS. And most people, even clinicians like athletic trainers and physical therapists, would not be able to tell the difference between MTSS and chronic compartment syndrome. The symptoms are very similar, and until you see it, it can be really difficult to tell the difference between the two. I've seen 5 cases of chronic compartment syndrome myself, and that honestly makes me somewhat of an expert because it's so unusual to actually identify it properly that most people will go their whole career without maybe even seeing it once. Last but not least of the ankle injuries we will discuss in this chapter is an Achilles tendon rupture. This is a graphic of what an Achilles tendon rupture might look like. So we get some tearing, some or complete tearing of the fibers of the Achilles tendon. This is more common in men over 30 playing an explosive sport like basketball or football, especially if they don't play the sport on a regular basis. So this would be more common with what we call weekend warriors. So somebody who maybe isn't working out a lot during the week and then goes out to play basketball for fun on the weekends, it would be more common. But technically can happen at any age. The youngest person I've had this happen to was a 19-year-old female soccer player. So it can happen again with just about anybody. My favorite Achilles tendon rupture story was gentleman I was working with at a PT clinic who was in his 60s, and he was a dentist by trade, and he was out golfing and he got a hole-in-one and he got really excited and jumped up in the air and said woohoo and tore his Achilles tendon. So I mean, it can be even just stupid little things that happen as well. Our mechanism for this injury, it would be that a tight Achilles is more susceptible to rupture, so having appropriate flexibility here would help to prevent the injury. And a more common mechanism would be a sudden forceful plantar flexion. We're going to jump up into the air. A strong dorsiflexion or deceleration possibly could also cause it as well. Our signs would be that somebody would feel or hear a pop or a snap, and oftentimes people will say that somebody kicked them. That's what it feels like, that they got kicked or they got shot in the leg. That's a very common way for people to describe the feeling that they get from this, because it is such a strong tendon, and so when it tears, it kind of feels like it released something. So it's like when somebody gets kicked. When this happens, the person can plantar flex. In fact, most of the people I've seen tear their Achilles can actually walk on it, but it's going to hurt. The plantar flexion is going to hurt, so they might be limping a little bit, but they'll still be able to walk on it, possibly. There's oftentimes a palpable defect where the Achilles tendon used to be attached. So in this region right here, it would feel like a dent or a divot in the Achilles. Our treatment here would be price. So ideally, we'd have the person on crutches or in a boot, or we would try to keep them non-weight bearing until they got those things. Most of the time, this is going to require surgical repair and then rehabilitation. Occasionally, if somebody has a partial tear, they may be able to get away with not having surgery, but even partial tears, I've even seen partial tears repaired in younger athletes possibly who weren't recovering. Rehab can take up to a year for this. When I was in college, we had a football player who tore one Achilles, and then 13 months later, he had just come back. I think he'd played in about a week or two of practice. He tore his other one. And if somebody has, large muscles and small tendons, this might be more common, say for instance. But it's definitely in the over 30 crowd. We're going to see this more commonly in the younger population. And that's the end of our ankle and lower leg lecture.